Yeah, you're welcome. Sorry for the delay. Had to sort out a thing or two.
That's
All
okay.
right, thank you. Let's move on to the types. So as I said, there are two major types. If the heart rate is less than 60, you classify that as a bradyarrhythmia. Just like the way we say bradycardia is heart rate less than 60. Heart rate is less than 60 and then your rate is abnormal. We say the patient has a bradyarrhythmia. Okay. And then the next one is if the heart rate is more than 100 and then sometimes you've got the rate and the rhythm being irregular, then we say the patient has a tachy arrhythmia. Okay. So with the bradyarrhythmia, you have the usual sinus bradycardia. Sinus bradycardia is what usually when you go and you do your ECG, they don't find any abnormality. They just realize that only the heart rate is low. Then we say you have a sinus bradycardia. Okay. It means that your heart rate is just basically what's slow. So there are some things that can cause a sinus bradycardia. And usually once you correct this, you'd have the heart rate going above 60. Okay. So if you have a patient who is extremely cold, the heart rate sometimes drops. So that's where we have hypothermia. If the thyroid hormone is also very low, like in hypothyroidism, as we talked about, we said hyperthyroidism, your heart rate would go up. Hypothyroidism, your heart rate will be low. So you can have some form of bradycardia. Okay, so that's sinus bradycardia. Sometimes when you have elevated bilirubin level in cholestasis, it has an effect on your SA node. Okay, the bilirubin has got an effect on your SA node, so it would suppress the rate at which your heart beats. Okay, so that would also cause a sinus bradycardia. And then raise intracranial pressure. So you have a patient who has had a head injury. We check the pulse and the pulse is slow. The reason is because of the head injury. The pressure in the head is gone up. So that is one of the ways of assessing raised intracranial pressure. If a patient comes to you after an accident and then you check and you realize that this patient's pulse is low, possibly there's some form of raised intracranial pressure. Okay. Then your beta blockers, as the name suggests, would slow down the heart. And then the digitalis would also slow down the heart. Okay, so those are extrinsic factors. Intrinsic factors are what would happen inside your body. Okay, so if you got like some form of medical condition like poor blood flow going to some part of the heart, and this part of the heart is where your SA node is basically sitting, then you are going to have a poor supply of blood to the SA node. And once this happens, you are going to have a reduction of oxygen to the SA node. The SA node would become a bit fibrotic, and then you are going to have problem with the natural pacemaker. Okay, so it makes sense. So that's why, as part of our etiology, we said ischemic heart disease, because ischemic heart disease, as I said, will lead towards poor perfusion to some aspects of the heart. And if this part of the heart contains any component of the electrical activity, you are in trouble. It's going to affect the rate at which your heart beats. Okay, so that's it. So sometimes you hear of a condition, we say sick sinus syndrome. Sick sinus syndrome basically is saying that your SA node, which is the natural pacemaker, has become fibrotic. So it's not hitting at the usual way it's supposed to hit. And as I said, if the SA node fails, the AV node takes over, and the AV node won't give you that 75 beats per minute. It will give you like 40, 45 beats per minute. So your heart rate will be low. Okay. So that is sinus bradycardia for you. Then you have bradycardia, which is indeed very abnormal because there's slow heart rate and then rhythm is also sometimes affected. Okay. And that is where the heart blocks come in. So usually when we are talking about slow heart rates, there are two main things. A sinus bradycardia, which we've seen the causes, is either intrinsic or extrinsic. Intrinsic, probably there's some ischemia or something. Extrinsic, you have other factors, maybe extreme cold and all that. Then you can say the cause is extrinsic, okay, raising intracranial pressure and all that. The other aspect is where we talk about the heart blocks, okay? That's the other aspect. So usually you'd have three main types of heart block: a first degree heart block, a second degree heart block, and then a third degree heart block. Okay, so your first degree, your second degree heart block is divided into two. We have type 1 and then type 2. Okay, we'll be seeing it very soon. So when do we say a patient has a first degree heart block, and what do we do if a patient has a first degree heart block? Okay, when you go back to the ECG, the normal ECG I showed you, you would see something, what we call a PR interval. Okay, so you can just scroll up to the normal ECG. Can we see a PR interval?
Yes, sir. Slide 5.
Yes, sir.
Good. So the PR interval is just the interval between where the P starts to climb as a mountain. Exactly. So the beginning of your P wave, not the peak of your P wave. The beginning of your P wave goes all the way to where you expect the R to start from. Okay. So that is a PR interval. The normal PR interval is about 0.12 to 0.20 seconds. Okay. Usually your normal PR is like a 0.12 to 0.20 seconds. What happens is that when you have a first degree heart block, this PR interval is what? It's prolonged. Okay. So you can see there's a prolonged PR interval, and it usually goes more than 0.22 seconds. So once you have a PR interval being prolonged, what does it tell us? Because we said that the P wave there is what? Atrial contraction, okay, or atrial depolarization. And then the QRS complex is ventricular contraction or ventricular depolarization. So the PR interval is basically the time it takes for the impulse to move from the atrium to the ventricle to initiate a contraction.
Okay.
Does it make sense?
Yeah.
Yes. So if we are talking about a bradyarrhythmia, we are saying that heart rate is what? Slow. So it means there's a slow, the interval is long because there's a slow transit of impulse from the atrium to the ventricle. In so doing, your PR interval becomes what? Longer than what's expected. And that is why you have a value of 0.22 seconds. In the same way, if you have a condition which is basically causing fast impulse generation from atrium to ventricle, we are going to have a shorter PR interval, because as soon as the impulse is generated quickly, in less than 0.12 seconds, it gets to your ventricle. So your PR interval will say is what's short. So that's what it means. So the longer PR interval, the longer the PR interval, the more slow your impulse is basically moving from the atrium to the ventricle. Okay. So when you say first degree heart block, usually that is the issue they have. PR interval is what's long. So when you take your ECG, you try to measure if you are suspecting that, oh, this patient might have some form of arrhythmia, because you've checked the pulse, okay? And then the pulse is what? Is slow. So this is how you assess. You've checked the pulse is slow. So you know, all right, this can either be some form of sinus bradycardia, or patient is having some form of what? Heart block. How do I determine? Sinus bradycardia, when it comes, you calculate your heart rate, okay? And then you realize that your heart rate is what's slow. Sometimes the ECG will tell you what the heart rate is, okay? To calculate the heart rate, you take the QRS complex, like the way your RR interval is, okay, you count the number of boxes between your RR interval and then you divide 300 by that number of boxes. That will give you the heart rate. Okay, does it make sense?
Yes, sir.
So if you take your RR interval, the number of boxes, big boxes in between, just divide 300 by that. So if you have like 5 big boxes in between your RR interval, okay, you divide 300 by that. So 300 by 5, then you get 60. So 60 beats per minute. Okay. So, but now most of the ECGs will give you the heart rate. So you've taken your ECG, you've checked, heart rate is less than, heart rate is around maybe 50 beats per minute. Okay, so yeah, when you check the pulse was slow, heart rate is indeed 50. So is it just the sinus bradycardia or there's an abnormality on the ECG? Some of the ECGs will tell you sinus bradycardia straightforward. Okay, sometimes you don't put it on it. So you have to now come and check, is the P wave normal? Is the QRS complex normal? Okay, you know what you are looking out for. So P wave, let me check the seconds. You look at the time. All right, P wave is between 0.12 and 0.20. So this patient, I don't think this patient has a first degree heart block. Okay, so that's how you assess it. So first degree heart block, your PR interval will be prolonged. Okay, the second degree heart block, as I said, there are 2 types. You have what we call the morbid type 1. The other name is Wenckebach, okay? And then the morbid type 2, okay? So when you take a look at the morbid type 1, you realize that there's some sort of a progressive, you have some P waves, okay? And sometimes not all the P waves, but some of the P waves will fail to conduct. So ideally, when you take your normal ECG, when you see a P wave, the next thing you are supposed to see is a QRS complex. Okay, when you see a P wave, you're supposed to see a QRS complex. But in the how do you call it? In the second degree heart block, some of the P waves will fail to conduct. So you see a P wave, but then you might not see a QRS complex following that P wave. Then you see another P wave with a QRS complex. Okay. So basically that's a second degree heart block. Some of the P waves fail to conduct. So on your ECG, you find a P wave without a QRS complex. With a type 1, you realize that it basically follows a certain pattern. Okay, so you have a P wave, then moving on, you have a QRS complex. Then you have another P wave, but then no QRS complex, and no QRS complex. Then you come back again. Then you have a P wave, QRS complex. So it tends to follow a certain pattern. Okay, so you can have a P wave and a QRS complex, a P wave and a QRS complex. Then all of a sudden there's a drop. There's a P wave without a QRS complex. Okay, then it comes back again. P wave, QRS complex, P wave, QRS complex, third P wave, QRS complex. Then there's a P wave without a QRS complex. So it follows a certain pattern. The pattern is usually 2:1, meaning that you can have a P wave and a QRS complex, another P wave and a QRS complex. Then the third time where you want to have a P wave and a QRS complex, you don't have that. Okay, there's a P wave, but then there's no QRS complex following it. Okay, then it starts all over again. P wave, QRS complex, P wave, QRS complex. Then you have a P wave without a QRS complex. If you move to the next slide, it would make more sense. So you can just move to the next slide and then I'll show you what I'm talking about. So the next slide, the part where we've written longer drop, okay, meaning that there's a certain pattern that is following. So you can see a P wave, okay, then after the P wave, there's a what? A QRS complex. I'm talking about the second one. Okay. I don't know if you can see it. Yeah. Not the first one. Yes. Yes, number 10. Slide number 10.
10, yes.
Okay. Yes, slide number 10. The parts where we've written longer drop. Okay. That is type 1 of the second degree heart block. So there's P wave, and then there's QRS complex. You can see that. Then now you come and have a T wave. Then there's another P wave and there's a QRS complex. You can see that. Then there's another P wave and there's a QRS complex. Okay, so it means you've seen 3 P waves all having QRS complexes. Then the fourth time there's a P wave, but there's no QRS complex. Then it starts again, P wave, QRS complex. Did you get it? So if we're supposed to continue this pattern, we are now going to have another 3 P waves with QRS complexes. Then there's a drop where you have a P wave without a QRS complex. All what you are trying to say is that there's a P wave which will transmit an impulse to the ventricle. P wave means atrial contraction, pushes blood and it gets the ventricles contract. Then there's another, the process repeats. So atrium to ventricle, but it gets to a point where the atrium doesn't, or the impulse generated in the atrium fails to get towards the ventricle. So at that point, there's a drop. There's no QRS complex because there's no impulse getting towards the ventricle. And that is what we call type 1 second degree heart block. Do we get it?
Yes, Doc.
Yes. And then the type 2 second degree heart block, the mechanism is basically the same as the type 1, but this time there's no regular parting. It can just happen at any time. Okay. So this one, so some of the P waves fail to conduct, but then it doesn't follow a certain parting of having drop, then another 2 P waves, QRS complex, and there's a drop, or 3 P waves, QRS complex, drop, or it doesn't follow that pattern. Okay, you can have a P wave now in a QRS complex, then all of a sudden you have another P wave with no QRS complex. Okay, then you have another P wave with a QRS complex. So it doesn't follow a particular pattern. Okay, unlike what we call the morbid type 1. Okay. Any questions so far? If you have questions, you can unmute and then ask, and then we go on.
It's a little complicated, but maybe when we read over, we'll understand.
You get it. So just like what will make it easier for you is just like we know that the first degree heart block, the PR interval is what is prolonged. Okay. The second degree heart block, where we are saying sometimes you have a drop, it means you have a PR interval, you have a P wave, but then sometimes it's not followed by a QRS complex. Just keep that in your head, that second degree, sometimes you have a P wave, and instead of having it being followed by a QRS complex, you don't have that. Okay, and then the type 1, what will give you that kind of, sometimes you have 2:1, 3:1 drop is that there's a gradual prolongation of the PR interval. Okay, so when you even look at that same longer drop, okay, you'd realize that looking at the first peak, the sharp point, and the second sharp point, okay, so you look at that, and looking at the second sharp point and the third sharp point, and looking at the third sharp point and the last sharp point, you've got some difference in length. I don't know if you can notice it. So the first sharp point to the second sharp point, okay, comparing that to the second sharp point and then the third sharp point, you realize that the distance between that is the same. Can you see? So the RR interval, Okay, the first RR interval and the second RR interval are the same.
Yeah.
But then,
The
last one, the RR interval appears a little bit longer than the first and the second. So that is what we call the type 1 or the working back, because there's a gradual, basically the PR interval would gradually become, it will gradually increase, and then eventually you have a drop where you don't see a QRS complex. Okay, so something like this, you can say that it's more of 2:1, because you have one RR interval over there. The next RR interval is the same, but then there's now a drop. In that drop over there, because of that drop over there, there's an absent QRS complex. Okay, so now there's a drop. There's an absent QRS complex. So it has made the space between the last but one and then the last one longer. And that is what we would say 2:1. So longer, then it drops. Okay, unlike the morbid type 2, where you don't have that kind of longer thing. Okay. Is it confusing?
It's a bit, but I think if we, as Madam Esther said, I think if we stay with it, for some time, it will catch you.
Okay, don't worry. So you try and then you read through, and then when we meet again, we'll just go through that one. Okay.
All right.
Yes, sir.
So the key thing you should keep here is that first degree heart block. There's a prolonged PR interval. Okay, which we've talked about. The interval between the start of the P wave and then the QRS complex. Okay, so there's a prolonged PR interval, so it's more than 0.22 seconds. Then just know that the second degree heart block, some of the P waves will fail to reach the ventricle. So you will have, ideally when you have a P wave, you should see a QRS complex. But sometimes you have a P wave, but then there'll be no QRS complex. As soon as you see this, as soon as you see a P wave without a QRS complex following, then this is a second degree heart block. So now you have to tell us if this is a type 1 second degree heart block or a type 2 second degree heart block. Okay, and how do we tell this? You realize that for the type 1 second degree heart block, there's usually a parting before the QRS complex disappears. It follows a certain pattern. First, you see normal RR interval, and then all of a sudden, you don't find a QRS complex. So it follows a certain pattern. But then with a type 2, it doesn't follow any pattern. So you can have a P wave, then all of a sudden, there's no QRS wave, how do you call it, wave? Do you get it? So there's P wave, and then there's no QRS interval all of a sudden. You can have a P wave, then another P wave, then there's a P wave, but no QRS interval. There's no pattern to it, okay? But then with the type 1, it will follow the pattern. So if you have maybe 2 RR intervals and then a drop, the next one, there'll still be 2 RR intervals and then a drop. It follows a pattern, okay? So the next time we meet in class 2, maybe an illustration on the board will make it easier. So just know that type 2, some of the impulses will fail towards reach the ventricles. So you have a P wave, but then no QRS complex, exactly. Okay. Then the last one is what we call complete heart block. So basically there's a complete dissociation. Whatever is happening in the atrium, it's not getting into the ventricles. The atrium and the ventricles are not friends. So the atrium is contracting on its own. It means there's a P wave. The ventricle is contracting on its own. There's a QRS complex, but they are not close together. So there's a P wave somewhere, then there's some QRS complex too somewhere. There's no connection. Okay. So that is a third degree heart block or complete heart block. It's a complete dissociation. So the SA node is beating, but then it's affecting only the atrium. So now the ventricle will also have to initiate its own contraction. And as I said, if the SA node stops working, AV node will take over. If AV node stops working, bundle branches will take over. That's how the electrical activity is. Okay. But then once you progress down, your heart rate tends to be even more slower. If SA node is 75 and AV node is 45, your bundle branches will even be lower than 45. So your heart rate will be very slow. So in third degree heart block, SA node is beating, all right, and that's affecting the atrium to contract. But then there's a complete dissociation. So the impulse fails to get to where the ventricles. So now the ventricles will generate their own impulse from either the Purkinje fibers bundle branch. Okay, so on your ECG, you see a QRS complex somewhere and then a P wave somewhere. Okay. So that is a third degree heart block. So if P's and Q's don't agree, then you have a third degree heart block. So it shouldn't be difficult. So first degree, PR interval is long. Second degree, there's not all the P waves will give you QRS complexes. And third degree, there's a complete dissociation of P wave from QRS complex. Okay. So that's your bradyarrhythmia. So as I said, bradyarrhythmia, you have your heart blocks and your sinus bradycardia. For tachyarrhythmias too, you can have a sinus tachycardia if some lion is chasing you, your heart rate will go up, but the rhythm won't be abnormal. So that is basically a sinus tachycardia. Okay. And then you have the atrial arrhythmias, where you can have a supraventricular tachyarrhythmia and then a ventricular tachyarrhythmia. Okay. The name, it shouldn't be confusing. The name sounds big, but it basically tells us where the arrhythmia is. So it shouldn't be confusing. Supraventricular tachyarrhythmia means that the arrhythmia is what? Above the ventricles. So we are talking about what's the atrium. Tachyarrhythmia means that the arrhythmia is in the ventricles. So supraventricular tachyarrhythmia is the same as atrial tachyarrhythmia. But medically, we don't say atrial tachyarrhythmia. We just say supraventricular. So it's above the ventricles. And then there's ventricular tachyarrhythmia. Okay. So I'm sure you've all heard of atrial fibrillation and atrial flutter. We'll talk about atrial fibrillation and flutter in our next lecture. So atrial fibrillation means that the abnormality is where up there in the atrium. So it is what? Above the ventricle, so supraventricular. Okay. So with supraventricular tachyarrhythmia, I have atrial fibrillation, which means that as the name suggests, tachyarrhythmia. So it means the atrium is beating faster than usual. Okay. And whenever you see the word fibrillation, it means the rhythm is irregular. So it means there's fast and irregular heartbeat. That is what atrial fibrillation means. And atrial flutter, another word is atrial tachycardia. So as the name suggests, the heart rate is, the atrium is beating faster, but then the rhythm is what? Regular. That's what it is. And then the ventricular tachyarrhythmia, it uses the same nomenclature as the above. You have ventricular tachycardia, which means the ventricle is beating faster, but then the rhythm is what's regular. And then you have ventricular fibrillation, which means the ventricle is beating faster and the rhythm is also what's abnormal. So to understand this, just understand the words fibrillation and tachycardia. Okay, so fibrillation means irregular and what's fast. Tachycardia means it's just what's fast. So supraventricular tachyarrhythmia, you are looking at two things. Either atrial fibrillation, which means that the atrium is beating what's fast and what's abnormal, okay, or irregular, or atrial flutter, which means that the atrium is just beating fast, okay. And then we can have ventricular tachyarrhythmia, which you have the ventricle beating faster or is beating fast and abnormal. So ventricular tachycardia means it's just beating fast. Ventricular fibrillation means it's beating fast and abnormal. So that is the nomenclature. Once you take a look at it, it will be easier. So what happens is that once you have any form of abnormal heartbeat, then you are going to have an issue with what? The blood that is getting into the circulation. Okay, so the clinical features are because you have less amount of blood getting into the circulation. How? Remember we said that cardiac output is heart rate times stroke volume. So ideally, if your heart rate is very low, then it means your cardiac output will be what? Will be low. So patients who have bradyarrhythmias, because their heart rate is low, they tend to have a what? A low what? Cardiac output. Does it make sense? Because basically there's low heart rate. So when you multiply that heart rate by stroke volume, cardiac output will be low. Once cardiac output is low, then you're going to have poor perfusion to vital organs. You feel tired early, you feel dizzy, you feel like collapsing because you don't have enough oxygen getting into your brain. Okay, so when you have a bradyarrhythmia, slow pulse, like what we have in heart blocks and all that, you realize the patient will come to you, patient will be dizzy, patient comes to you, patient will be tired, sometimes they can just collapse, complete heart block, sometimes they can just die, okay, because the heart rate is low, so cardiac output is also what's reduced. Now on the opposite side, your heart rate is fast, so then we expect that your cardiac output should be what? High, but that is not the case, okay? Your heart rate is high, however, because the heart is contracting too fast, it doesn't have enough time for it to be filled with what? Enough blood. You remember we said that the amount of blood that you pump into circulation, that is what? The stroke volume, is dependent on the amount of blood that is coming into what? The ventricles. So if you have lots of blood coming into the ventricles is able to stretch and pump a lot of blood into circulation. But if you have less blood coming into the ventricles, then the ventricle cannot generate enough stretching force to pump blood into what? The circulation. And that is what happens when you have what? A fibrillation, okay, or an abnormal tachycardia. Because the heart is beating so fast, okay, it fills, but then it doesn't have enough time to fill completely. So as soon as the blood is entering, the heart is contracting. So you have less amount of blood being pumped into circulation. Hence, you also have poor perfusion. So you're going to have dizziness, tiredness, sudden collapse. And because your heart is beating fast, you have what? Palpitations. Okay. Are we okay with the explanation for the clinical features?
Yes, sir.
All right. Okay.
Yes, sir.
Okay, great. So the investigations is basically straightforward. If you are suspecting an arrhythmia, what you do is an ECG, a 12-lead ECG, straightforward. So when you do it, the next time we meet, we'll try and go over heart block, we'll go over ECG for atrial fibrillation, we'll go over ECG for atrial flutter. So then when you see it, you know what you are looking out for. We'll go over ECG for ventricular fibrillation. And even by the time you are done presenting your cardiac arrests and all,
Doc, your network is quite stuttering. We can hardly hear you.
Normal ECG that's we are. So basically, yes, ECG. Then, of course, you do a supportive test. Sometimes you'd have to do a chest X-ray. That's with my other phone, and someone called. So,
okay,
is it better?
Yes, it's better now, though.